they were running a whole bunch of campaigns on smoking cessation, and they were showing people who were putting on prosthetic limbs and stuff because they had to have their legs and arms cut off because of Berger's disease. Long-term smoking. No specific diagnostic test, really they rule out everything else and say you really need to quit smoking. So biggest treatment is tobacco cessation, and analgesics for the pain. Most of the time debridement, wound care, and then amputations. As far as Raynaud's, we've got Raynaud's phenomenon, we got Raynaud's disease. This is an idiopathic or unknown cause, could be an autoimmune disease. It can be primary, it can be secondary. Secondary is usually caused by some kind of connective tissue disorder like lupus, COPD, eating disorders. There's a lot of different things that can cause Raynaud's phenomenon. And then the idiopathic cause, many times it runs in families. You see it most of the time in young women. It starts in their teens. Smoking certainly is going to worsen it. They have linked it to things like hormones. People who have Raynaud's are also more prone to have migraines. And what did I say? That's pretty much it, I think. Biggest triggers here, stress and cold for Raynaud's that we see. It definitely can be painful. And that's what you're seeing, is that the extremities will turn from a bright red to a white to a blue, usually precipitated by something. So teaching-wise, besides handling the underlying cause, if they can figure out what the underlying cause is, we need to teach them to avoid the triggers. So certainly, wear your gloves, your mittens if you're going out in the field. Wash your hands in cold water. We want to think about decreasing stress, decrease emotional upset, don't smoke, don't take caffeine. Biggest problem is that as they have this period of that red, white, blue color, they can have breakdown and small little pinpoint wounds and holes in the fingers and the toes when this is happening, and it can turn gangrene if it's not treated. Diagnosis, if they can't find an underlying cause, it's really going to be dependent on symptoms, and after 2 years of having these symptoms regularly, they'll finally say that you have Raynaud's. So it takes a while to actually diagnose it. That's pretty much it. I told you avoid the triggers. Some medications that they could possibly be using. One of the most interesting is going to be the Viagra that they have tried to use to treat the Raynaud's on women. Some of the calcium channel blockers or angiotensin II. The most severe cases, they can do a sympathectomy, which is going to sever the disruption from the sympathetic nervous system, because as fight or flight, stress, emotional response is going to cause the constriction or the vasoconstriction to get worse. So they can sever those nerves in order to prevent that constriction from occurring. Right, questions, because we're going to move on to the venous then, before we're done. So, when we're looking at venous problems, now we're thinking about thrombophlebitis. And thrombophlebitis has a very large range, going from our superficial thrombophlebitis that we look for, all the way up to a venous thromboembolism, and with a DVT somewhere in the middle. You can also have a patient who has chronic venous insufficiency, which means that the blood is just not pumping back up to the heart as easily as it should, and then our varicose veins patients. So with thrombophlebitis, this is going to be inflammation and thrombus formation that's occurring in the veins due to injury in the epithelial lining. So what we do is we have the inflammation set up. Again, you have the clotting cascade that starts, so we get that platelet aggregation. This is now occurring in the veins. And it is just setting up this whole chemical inflammatory process, which then can lead to vessel occlusion or embolus. Risk factors here: immobility, trauma, childbirth, hormonal contraceptives, abdominal surgeries, joint replacement surgeries. Biggest risk factors in these cases. When I'm looking at thrombophlebitis, it could be superficial or it could be deep. So our superficial is usually the self-limiting type. It rarely results in somebody ending up with DVTs or the pulmonary embolism. However, if it's deep, this is the person person who is having thrombophlebitis in the larger veins, like the femoral and the iliac, and usually this is a more progressive type that can lead to the development of a DVT, and if a DVT breaks off, well then that can travel back up to the heart and can end up as a pulmonary embolism. If that is happening, then we refer to it as the venous thromboembolism, the one that is broken off and is lodged somewhere else, usually ending up as the pulmonary embolism. And Bearcross triad is the triad that is leading up to the problems with these deep thromboembolisms that are occurring, so the deep DVTs. So you have three things going on: venous stasis, usually due to immobility, inactive extremity muscles. This is why if somebody's traveling for long periods of time, they tell them to get out of the car, walk around, or sit for long periods of time. Because any change in undirected blood flow can lead to the clotting and the breaking off of the clot. Endothelial damage, well, anybody that has any type of arteriosclerosis or hypertension or diabetes or pretty much any chronic disease that we've talked about in that nature can have endothelial damage. And then the chance for blood hypercoagulability. So this could be a person who maybe just hasn't drank enough, maybe they're a little bit dehydrated. Any type of change in coagulation of the blood. These three things together lead to platelet aggregation, the clotting factors, the clumping of blood, and then that whole clotting cascade taking off. Forms a thrombin, and the thrombin always has the chance to form into an embolus. So as far as clinical manifestations, superficial versus deep. With superficial thrombophlebitis, this is usually a palpable cord that is running along the affected extremity. You see this with, we watch for this with patients with IVs in. We're looking for superficial thrombophlebitis, pain, tenderness, swelling, redness, any type of induration. Cord-like, it's one vessel, it's a superficial vessel. Versus our deep thrombophlebitis. This is a patient who may experience malaise, fever, chills, severe pain. Here's where we see a swelling of the extremities, although it's usually non-pitting in the beginning. Heat or warmth to the extremity, cyanosis, if there's a distal blockage somewhere, and then positive Holman sign. However, we don't check for the Holman sign, but if they did, it would be positive. So pointing the toes up to the nose is gonna cause pain in the calf, is basically what's gonna happen with our deep thrombophlebitis. Diagnostics on the Doppler ultrasound can identify the reduced blood flow. They can go for a CT, and then a venograph can show the filling defect or the diverted blood flow, but that's not used for any type of routine screening. And that does use contrast media. So they're gonna do the less invasive procedures first. As far as care, prevention is the biggest thing. For anybody that you know that has risk factor of thrombophlebitis, we need to, number one, make sure that they are doing what they can to prevent problems. So this may mean that they're on a anticoagulant, especially if they have higher risk of developing the clots. Or if they know that somebody frequently throws a lot of clots, they can insert the vena cava orvella or the vena cava filter, especially before going for any type of surgery. So this is gonna trap emboli that can be being thrown back up through the vena cava, preventing it from getting to the heart to going into a pulmonary emboli. And I have a picture of it on the next slide. All of this is usually done to reduce a risk of developing a clot, especially for the person, again, going for any type of bone joint surgery, abdominal surgeries, or replacement surgeries. So this is what the filter looks like. They're gonna insert the filter into the inferior vena cava, and this will help to catch any little clots that happen to be being thrown from somebody who has a known history or high risk factors of clots. Other preventative measures, we're going to do range of motion for patients who are on bed rest. We're gonna be using the intermittent compression devices or anti-embolism stockings. This is a big thing in the hospital setting. They're always talking about prophylaxis for DVT. Monitoring for anybody for signs and symptoms, pulmonary embolism, and then if the person is on anticoagulants, we need to watch for bleeding. Now, for somebody that does have a DVT, we need to prevent further increase in the size of the thrombus, control pain, and prevent reoccurrence. These are some of the big things. Specific treatment, this person will be on bed rest. The entire length of the extremity needs to be elevated in order to decrease edema from occurring. So if it's the leg, well then I need to elevate the entire leg from the hip to the feet. And the feet should be up higher than the hip. So think about your methods of positioning in order to accomplish that. We're gonna be recording the circumference of the extremity that has the clot in it. So again, if it's the leg, I'm going to record the circumference of the leg every shift. We're gonna mark it at the location that we're recording it at, so everybody's measuring it at the same location, because I wanna see if the edema is getting any bigger. Warm, moist, heat application. That's something that they always like to ask. What heat, or what application, wet, dry, dress, or what application, you want heat or you want cold? In this instance with the DVT, we want warm, moist, heat. Oral, non-steroidal anti-inflammatories can be given. Anti-embolism stockings, if I'm putting them on, I go on before the person gets out of bed. Now, for somebody whose DVT is not symptomatic, they can potentially be able to get out of bed and walk. And then certainly for somebody who has superficial phlebitis, say from a IV, we remove the IV, we're gonna take out anything that's causative, and they get the warm, moist heat on the extremity where that is located.
Because I was worried there was gonna be stuff on here that had freaking like 81%.
So the difference between a small DVT, this is the person that they say that can actually get out of bed and walk around, because their newest evidence say that with the smaller DVT, there's no increased risk that walking is gonna cause a pulmonary embolism to occur. So actually, early exercise could potentially be prescribed, or walking or range of motion for somebody with a small DVT, but remember, if they are having edema, when we lay them down, we need to prop up the entire length of the extremity. So they may be having exercise or ambulating every day with a DVT. Anticoagulants, most of the time you're using a low molecular weight heparin like Lovenox. That's gonna prolong our clotting time. Later they may switch them to an anticoagulant. And let's see. Acute care, if they wanna use a thrombolytic to try and break up a clot, well, we know we have lots of different thrombolytics to choose from, so something like Alteplase. And other things they can do would be the complete endarterectomy or embolectomy. So, patient teaching, avoid prolonged sitting, avoid prolonged standing, how do you apply anti-embolism stockings, and then teach them the signs and symptoms of the clotting. Make sure that you know how to teach them to go home with Lovenox if they need to give themselves their own injections. So that's the DVT. So for somebody with chronic venous insufficiency, what we're looking for here as far as symptoms, these are the patients that complain about their leg heaviness, swelling, aching legs. With very, very severe venous disease, now the blood is not going back up to the heart, so it's getting trapped in the veins are becoming engorged, they're putting pressure on the tissues, and they're gonna cause wounds. So we're gonna look for venous stasis ulcers. Where do we find these ulcers? It could be on the front of the shins, the medial malleolus, they're gonna be on the calves somewhere, because this is where the swelling is occurring. They also get discolorations. So with chronic venous insufficiency, again, the blood is just not going forward, usually due to problems with the veins, allowing black backflow of blood or not closing completely. So other clinical manifestations, pruritus, itching can be caused, their skin becomes leathery in appearance, it takes on a brawny, brownish appearance, and that's because the blood, as it's breaking down or sitting in the legs, the RBCs are being broken down and the heme is being given off and it sits in the tissues. So it makes a brown, blue, or brown-black discoloration.
Is this the one where they leak?
Yeah, leaking, because that fluid, again, the inflammatory process is sitting there. And the fluid has nowhere else to go other than out around the skin so they can get leaky legs. Fibrous tissues replacing the skin and subcute tissue so they get the hardening, thickening, contracted skin. Chronic swelling of the legs and ankles, And then the hydrostatic pressure, as it increases, now we're getting that pitting edema that's occurring. And that's where you can see the weeping of the legs. Lymphedema, it's very hard to palpate their pulses, not because they don't have them, because their arterial is fine. It's because they have so much edema in the legs. They get stasis dermatitis or eczema, so now their legs can be flaking and it looks like the skin is sloughing off of them. Increased skin temperature, usually at the ankle. Cyanosis in a dependent position, again, not because there's an arterial problem, because the swelling is putting pressure there. Ulcers are usually above the level of the medial malleolus, they're painful. A lot of times they get infected easily, they get lots and lots of episodes of cellulitis. Biggest complication are gonna be non-healing ulcers here that require amputation. When we're thinking about these types of ulcers, wet to dry dressings, they may be using wound vacs on them, wrapping the legs with the compression wraps. They'll use the 2 wraps because it's all about getting the swelling down. These are the patients who you need to, again, keep their legs elevated in order to keep that swelling down. So this is looking at the risk factors and the difference in how the fluid is being forced into the tissues based on the hydrostatic pressure and what their legs can look like in this situation. Many times they can look at D-dimers. Positive D-dimer tests are going to be there because of all of the thrombosis that are associated with all of these varices. They can do the color flow duplex ultrasounds, MRIs, and then venograms. And then collaborative care. Again, compression is gonna be compression devices, compression stockings, they can use Una boots, they can use multi-layer ACE wrap bandages. Skin lubrication, we wanna keep that skin well cleaned and lubricated to avoid it from breaking open and getting wounds. They can be on antihypertensive therapy. As far as nutrition, lots of protein, vitamins A, C, vitamins for the skin are gonna be important, zinc. Weight management, normal blood glucose for diabetics, again, frequent rest with legs elevated with at least like a 7-inch wedge pillow. Walking is okay, but make sure if they're walking, since that's in a dependent position, we have compression stockings on or the wraps on when they're walking. If they're having dressings, it's usually going to be a wet to dry or moist environment wound dressing, and then treating infections as needed. So there are some treatments that they can do surgically, like the subfacial endoscopic perforator vein surgery. I haven't really seen this done that often, but what they're gonna do with this instance is they use a balloon to kind of help separate the veins from the surrounding tissue and identify the incompetent veins and clip them, so that they are trying to fix the incompetent valves that are not working. This kind of decreases that venous hypertension, so decreases the amount of pressure being, hydrostatic pressure pushing the fluid out into the tissues. So biggest thing to remember, difference between arterial and venous problems. If you can keep it straight in your head and you can keep the treatment, the nursing care straight, that's the most important thing you do. Just don't confuse the arterial with the venous signs and symptoms. And then the very last thing, just varicose veins. So varicose veins are very common in somebody who stands for long periods of time. So these are going to be our dilated, tortuous veins being caused by incompetent valves. Most commonly, it's going to start in the large saphenous veins. So